Hematology. This session is for both uh, clinical hematologists and those working in the laboratory. And I would like first the laboratory staff, either a biomedical scientist, medical lab technologist, or medical lab scientist, to comment on the blood film first, because they are the people, they are the gem people who report the blood film first. And if they think that this is a serious one or has some findings, then they refer it to the clinical hematologist. Then the clinical hematologist will report the blood film as required by the FRCPath exam, and then few questions as we see in the exams. All right, so the first case. Right, so this is a 35-year-old female who presented to emergency department with progressive fatigue and tiredness sent by GP to the emergency department. The full blood count shows hemoglobin of 110, white cell count of 21, and platelet count of 140. So the biomedical scientists have made the blood film, and he is going to report it now first. So anyone who wants to report it first from the lab side, please.
So actually screen is not visible to me. I don't know if I have some problem from my side.
Is the screen visible to everyone, or just you
Sir,
had the
screen is
problem?
visible, but pixels are very much distorted. Like
Sorry?
The
it's
screen is
visible, but it's
visible.
not clear. But not clear.
Yes,
Yes,
it's
because
visible now.
because this is power
Visible.
10, I will move to power 50.
Yes, it's better. It's better now. It's better now.
Anyone from the lab side who want to comment on it first and then refer to clinical hematologist?
Um, Sir, there are spherocytes. Along with that, few atypical lymphocytes are seen. NRBC is there, and the lymphocyte has got abundant cytoplasm. Can you please magnify it further?
Okay, so I will go through the blood film first at power 10 to give you an overview of the film. This was power 10. Now I will move to power 50, the oil lens.
Some stomatocytes there.
Okay, so let's see some other fields.
Blast. Stomatocytes. Thrombocytopenia. Blasts.
Okay.
The atypical large lymphoid cells are seen.
Are there vacuolated cytoplasm? Look like are not clear in the picture.
Okay, let's see some other blasts we have. We'll add some more oil to that. We get a clear picture.
Sir, it seems
There are
more like
some
a monocytoid blast.
there are some granules present here. The red dots you can see. See in the
Hello.
hundred.
Hello.
Yes, you can see.
Yeah, it's an
Or
AML. I
rod
can
can
see
be
our
seen.
rod. No
Or rod
rod.
can be
See
seen
our
in this
rod.
blast.
There is an R rod.
Yes. It's an AML M1.
Uh, there is no M1, M2, M7 in UK anymore. We do not use the old Pathclassification now. We use the WHO 2022 classification in UK. This is another block. Right. So as a um, lab scientist, you have noticed blast and you are thinking this is acute leukemia, and you have referred the blood film to a clinical hematologist. So now I want a clinical hematologist to report this blood film for the purpose of FRCPath exam. Any clinical hematologist?
Sir, can I?
Yes, go ahead.
Okay. This is a peripheral smear showing normocytic normochromic red blood cells, and so the slide is now blurry, and there are medium to large sized atypical cells having folded nuclei and 2 to 3 nuclei and slightly granular cytoplasm. Few of the cells show the presence of or rods,
Mhm.
and and also platelets are reduced on the smear, and the fields which we examined so far, I found only 1 or 2 platelets, and the features are suggestive of acute myeloid leukemia. Um,
You're thinking this
More,
is acute myeloid leukemia.
yes, sir, the features are suggestive.
Yeah,
Most
so
likely monocytic.
never say never say diagnosis on a blood film. You should
Oh,
say the the blood film findings are most likely consistent with acute myeloid leukemia, but we need to confirm that with flow cytometry and cytogenetics and karyotyping as well. Because
Right, sir.
there may be a lymphoid population hidden in the blood film which we haven't seen. Maybe this is MPOL. May it turn out that as
Right.
acute lymphoblastic leukemia. So without flow, you cannot comment on the exact diagnosis. You always say most likely this diagnosis, but we need to confirm that. And first comment on the abnormal findings. You have seen multiple blasts. This blood film contain uh, multiple blasts, which are large in size, having indentation in the form of fish mouth. Fish mouth indentation in the blast are a feature of
NPM1 mutation.
Sir, NPM1 mutation.
yes, but it is not necessary that
NPM1
they will be
has
present. Yes, go ahead.
NPM1 has a cup-like. I have read, but fish mouths. It doesn't look like cup-like.
This one, and we will see a few other as well. So I was saying that it is not necessary that in all NPM1 you will see the cup-like or fish mouth features, because NPM1 has multiple variants. So there may be cells which a blast which may have NPM1 variant mutation, but there is no cup shape or mouth shape, fish mouth shape appearance in them. But generally, it is considered that if it is a cup shaped or fish mouth shape, then you think that this is uh, NPM1. But that need to be confirmed on cytogenetic and karyotyping first. Like this one.
This one is
This one.
more prominent.
But there are, like I mentioned, there are multiple NPM1 variants which will be having different features, not exactly cup shape. Right. So you have commented on the blood film, and you have suggested flow cytometry and on the blood and bone marrow biopsy for this patient to confirm your diagnosis. Right. So the next question would be, what is the minimum genetic test requirement for any acute leukemia according to WHO 2022? Like you have done bone marrow biopsy for a patient, what genetic test you would like to see in the patient, in any leukemia patient?
PCR ABL1,
Uh-huh.
NPM FLT3,
Okay.
So translocation 822, translocation 1517.
Mm-hmm. All right.
MLL rearrangements,
Yeah. So the
KMT2A.
so the BSH and the WHO 22 guideline have mentioned that you need to send four things in any leukemia patient to reach a diagnosis and the prognostic classification. Karyotype, you have to see translocations on karyotyping. Molecular mutations by sending blood and flow for blood and bone marrow aspirate for NPM1, FLT3, ITD, and TKD. Then you need fish for 1517, 821, and KMT2A. This was the third thing. The fourth one is NGS panel for a whole lot of mutations. ASXL1, B core, SRSF2, etc. There are quite a lot, 16, 17 mentioned in the guideline. So whenever you do a bone marrow biopsy for a new leukemia patient, you send these things. FISH for 1517, 821, KMT2A, karyotyping to no translocation, molecular for NPM1, FLT3, ITD, and TKD, and NGS panel for the patient. And why do you send them? For treatment purpose, prognostication purposes, and it will tell you whether the patient has high risk features or not. Transplant is suitable for him in the future or not. Because if someone has TP53 mutation, he is a very bad risk person. Even transplant will not cure him. All right. So this patient has NPM1 mutation along with FLT3 ITD. What is the prognostic category of this patient?
Standard.
So standard.
Are you sure?
Sir, FLT3 ITD is a poor marker.
So
Poor
mutated
prognosis, FLT3.
mutation in NPM1 and FLT3 is also mutated. Is this a standard category
Okay,
or
both.
intermediate risk?
Okay.
Sir,
Intermediate, sir.
So that's
So according to WHO 2022 guideline, this is intermediate category if you have NPM1 with FLT3 ITD.
Yeah.
Right?
Yes, sir. NPM1 is a good, FLT3 is bad, and when both are present, this is intermediate.
So if NPM1 alone is mutated and there is no FLT3, it is a standard category. And if it is NPM1 plus FLT3 mutation, then it is an intermediate risk category. For intermediate and worse category, your aim is to give a patient an intensive chemotherapy if he is fit for that, to bring him into remission and send him for allogenic transplant. While standard risk category patients, they usually do better without transplant. Our aim is to give them intensive therapy and then maintenance if required. So this patient has now NPM1 mutation, FLT3 mutation. The patient is 35-year-old female, fit, no comorbidities. What are your choices of chemotherapy for this patient?
Anthracycline.
What is the name of the regimen that you give to a patient of AML who is fit? Either it is DA, daunorubicin, and anthracycline, or it is like either fludarabine-based chemotherapy. Because this patient has FLT3 mutated, so you add midostaurin to these patients as well. So either midostaurin or flag-ida midostaurin to these patients, and once in remission, then you send the patient for transplant. So this was an NPM1 FLT3 mutated AML. There are multiple variants of NPM1. So fish mouth and cup shape are not necessary to be present in all NPM1 mutated mutation. and always report the abnormality first in the report, and then your impression that this film is likely consisted with acute leukemia, and suggestion that you need urgent flow for this patient and bone marrow biopsy, including aspirate and tryptophan, to confirm your diagnosis. Then this would complete your report. And in the um, morphology question of the FRCPath Part 2, they usually ask you what is the minimum genetic test criteria for leukemia. They can also ask you what are the CD34 negative AML. They can ask you what is the prognostic classification of this AML, and what is the choice of treatment for this patient. Then you would mention both chemotherapy plus transplant in the future, if it is intermediate or worse, and if it is standard, then just chemotherapy. They can give multiple questions in the FRC form.
Sir, just one question. Are we expected in exam to pick NPM1 mutation on just morphology?
No. As I mentioned to the candidate who was reporting the film, you cannot say on the blood film that this is AML or ALL, or this is NPM1 or A21. You just say most likely consistent with
Okay,
uh,
sir.
this diagnosis, but I need to confirm that on flow cytometry and bone marrow aspirate and investigation. Because in real life, when we see any blood film, we don't say that this is KMT2 AML or 1517 APML. We always say this is most likely suspicion, but then we send blood to the HMDS, Malignant Diagnostic Service, or bone marrow aspirate to confirm our diagnosis. And once the diagnosis is confirmed, then we
Okay,
start.
sir.
So never say on the blood film that this is the confirmed diagnosis. Some things are very clear, like if you are seeing biloblasts in the blood film, then you would say there are biloblasts. This is a hematological emergency. I would start ETRA for this patient, but I would send a blood for PML RARA stain as well, which will give you result in 1 hour. And if PML RARA stain is positive, you are starting chemotherapy for the patient if the WBC count is more than 10. Right. So now we have another 40-year-old lady who is coming to the emergency department with easy bruising and 2 episodes of epistaxis. So this is power 10. So this is again a young lady who is coming to ED with easy bruising and 2 episodes of epistaxis.
Looks like
The
cold eggs.
cold eggs, right? And
Agglutination is prominent, red cell agglutination.
yes, the coagulation profile shows prolonged APTT, right? So
What about
anyone,
PT, sir?
sorry,
PT is
sorry,
normal?
PT is normal, APTT is prolonged, and the biomedical scientists have prepared the blood film. Is there any one from the lab who want to comment on this blood film and refer to hematology?
Yeah, it's definitely cold acts. Thrombocytopenia there, that would account for the bleeding. Looking at the neutrophils.
Okay, so this is
Look
power
at
10. I will move to power 50 to make it more clear to you. This
yeah,
is just oil movement, so ignore this movement.
certainly reheat this 37 in a block and rerun the sample.
Okay.
Definitely thrombocytopenia.
Mm-hmm.
Is this patient on warfarin? The PT is
No,
prolonged.
no, this patient is not on any anticoagulation.
What is the ESR of this patient?
We don't do usually ESR here. Why you want to know the ESR?
That's not Rulo. Definitely not Rulo.
There are many reactive lymphocytes.
Could this be some form of lymphoma? Mycoplasma?
Okay. So now you have commented on that there are cold eggs and there are some lymphoma cells as well.
Yeah, that's right.
You have now referred the blood film to clinical
Yeah.
hematology.
Yeah, definitely would have sent this in. Yeah, that's a really abnormal blast cell, maybe.
I need now a clinical hematologist to report this blood film for the exam purpose, FRCPath exam purpose. Any hematologist, clinical hematologist, please?
So may I?
Yes.
Okay.
Do you want to hear the story again, or you are aware of the story?
This is a peripheral smear of a 40 years old lady who came with a history of epistaxis and bleeding, and her APTT is prolonged, and this is the peripheral smear showing red cell agglutination, and there are atypical lymphoid cells seen, which are medium to large in size, and the features are suggestive of some lymphoproliferative disorder. I would uh, investigate further by flow cytometry, bone marrow aspirate and refined biopsy, and lymph node biopsy.
You're
And
doing lymph
also,
node. You're doing lymph node as well and bone marrow as well for both.
sir, because the history did not mention any lymph adenopathy, whether it was present or not.
Okay.
I
So the
have
patient, the patient has
if
the patient
yes,
has
sir.
abdominal pain only. The patient has abdominal pain, and the spleen is 22 centimeters.
Okay, I will go for PET or CT for lymph nodes, And also I would go for bone marrow biopsy to see infiltration, and also to for immunohistochemistry to categorize this lymphoproliferative disorder.
What are you thinking about? What this can be?
So does this patient need any workup for the serum protein
I'm
electrophoresis?
thinking of any B cell lymphoproliferative disorder because they are um, associated with cold agglutinin diseases.
Okay. So the blood film contains multiple cold agglutinins, and there are multiple atypical lymphocytes. Some are small in size, some are large in size, with minimum. Some have minimum cytoplasm, and some with abundant cytoplasm. I was looking for any whole jolly bodies, but I couldn't see because this patient had um, splenomegaly as well. So difficult to comment on the red cell and size and shape because of the agglutination. Due to the presence of atypical lymphocytes and cold agglutinins, there is a suspicion that this patient has a lymphoma. This patient needs um, blood to be sent for flow cytometry and further investigation to find out the cause of abnormal lymphocytes, which can be either bone marrow biopsy if cytopenias are present, because I haven't given you the full blood count, or a lymph node biopsy on imaging if there is any lymph node amenable for biopsy. Now, which condition gave you cold agglutinins?
Sir,
Most
So
may I ask a
lymphoplasmacytoid
question that you
lymphomas,
lymphoplasma
lymphoplasmacytic lymphomas,
Proteinemia.
LPLs, Vanderstrom macroglobulinemias,
So, Waldenstrom macroglobulinemia and
um,
Mycoplasma.
mycoplasma infection and
Uh,
infectious mononucleosis.
yeah, but the lymphocytes are not typical for the infectious causes of cold hemagglutinin disease. And on further investigation, to simplify it for you, mid 88 is negative. We have received the flow, and the flow is CD5 negative, CD20 negative, CD23 negative, CD10 negative, cyclin D1 negative.
it may be marginal zone.
Marginal zone lymphoma. I have given you the hint that this patient has splenomegaly, and the flow cytometry does not fit with Waldenstrom, does not fit with CLL.
Yes, sir.
So most likely
And
it,
you ruled out follicular and MCL as well.
yeah. So this most likely consistent with marginal zone lymphoma, and we are still
It was,
waiting for
sir, I
the.
was going to ask. I was going to ask a little question that you said on morphology description that there are cold agglutinins on the preface smear. Can we say this a cold agglutinin or just agglutination of RBCs?
This is the red cell agglutination, not cold agglutination. Sorry.
Yes,
This
and
is
sir,
the
I just I wanted to
this is the
ask
red.
another question that you said patient was bleeding. That can be due to acquired hemophilia like thing when immunoglobulin raised causes decreased effectors.
Yeah. So this would be a next question in the FRCPath exam. Why this patient is bleeding? Because this patient contain paraproteins, and paraprotein is a cause of acquired von Willebrand syndrome.
Yes, acquired one acquired hemophilia.
Yes. And acquired von Willebrand syndrome leads to bleeding in the patient. Any condition with paraproteinemia has a tendency to lead to acquired von Willebrand syndrome. Acquired von Willebrand syndrome has a lot of causes, and one of the causes is paraprotein. So Waldenstrom has paraprotein. You can see acquired von Willebrand syndrome with Waldenstrom as well, but in multiple myeloma, in marginal zone lymphoma as well. In multiple myeloma, you can see factor 10 deficiency as well, but acquired von Willebrand syndrome is also common in multiple myeloma.
Will you expect to see some plasma cells there, though?
Yes, I'm searching for that. If there is any plasma cell present in the film or not. But I had seen few plasma cells in this. All right. So what is the treatment option for splenic marginal zone lymphoma?
Splenectomy can be done.
Before splenectomy? Do you have any other option?
Sir, hepatitis C profile should be done.
Yes, it is commonly associated with hepatitis C. And what else you
The
can
interferon
offer?
treatment.
Interferon. What does the BSH guideline says? So this is the polarized lymphoma cell or splenic marginal zone lymphoma. It has projections on both ends, which is a feature of splenic marginal zone lymphoma. These projections and these. So if the patient is not symptomatic, you do not give any treatment. But if the patient is symptomatic, you start with either rituximab monotherapy or bendamustine plus rituximab. For the splenic marginal zone lymphoma.
So may I ask a question that I often thought so that as patient is CD20 negative, but rituximab is anti-CD20, I think. So how can it be used in this lymphoma?
The marginal zone lymphoma cells, they are CD20 positive. They are not negative.
Oh, okay, sorry.
B-cell lymphoma.
Dr. Amir, what about this granular lymphocyte which you focused just now?
One or two granular lymphocytes can be present if there is coexistent infection with that. But the majority of the lymphocytes were small lymphocytes with minimum cytoplasm, and they were lymphoma cells. And then the flow cytometry was according to the splenic marginal zone lymphoma.
Right. Thank you.
Right. Now again, we have 35-year-old male who was referred by the GP because of the abnormally high white cell count. The white cell count is 500.
There's a marked shift of myeloid series up to the level of blast. You can see, you can appreciate all the myeloid cells in it: neutrophils, promyelocytes, myelocytes, metamyelocytes.
This is
Along
power
with,
10. I'm just
and they're all
going
present in
to,
clusters.
I'm going to the film to give you an overview of the film, and now power 50.
This looks like a CML.
I cannot see any basophils in it.
So we have here band form, myelocyte, neutrophil.
I think myeloproliferative disorder would be a better term.
Blasts are here.
Basophil.
Somebody says basophil,
Yeah. I need to see more.
metamyelocyte. Mm-hmm.
Fine
Like
model
a,
peak with basophilia.
like a CML in blast phase. Okay.
The block percentage is 11%.
Right.
Accelerated.
There is no accelerated phase in UK anymore. Either it is a chronic phase or it is a blast phase treated as AML.
CML in chronic phase.
Yes, this is a CML in chronic phase. But I want you to report it for the purpose of FRCPath exam. How would you report this question?
So this peripheral smear is showing all the myeloid series, starting from blast, promyelocytes, myelocytes, metamyelocytes, and mature neutrophil band and mature neutrophils are seen. Along with that, these NRBCs are present, platelets are adequate. Few basophils are also appreciated in the smear. The red blood cells are normocytic, normochromic, and most likely the peripheral film is suggestive of CML in a chronic phase. So I would like to go for the cytogenetics and flow, and for PCR for translocations, 922 on PCR,
So you
and for
mentioned that
BCR ABL protein.
So where is the basophil? I'm sorry to cut you. Oh yes.
Basophil.
So we can see one basophil in this
This
field as
Yes,
well.
yes.
Yes, this one.
the blood film shows leukocytosis with a myeloid peak containing blast, myelocyte, metamyelocyte, band forms, basophil, eosinophils, NRBCs, and mature neutrophil, most likely consistent with chronic myeloid leukemia. Needs blood for flow and BCR-ABL, transcript mutation, and bone marrow biopsy if there is pancytopenia. If there is cytopenia. The
Dr.
hemoglobin,
Amir, question that when we advise the patient of CML PCR for the first time, do we go for qualitative PCR and then before initiation of treatment we go for quantitative, or we straight away go for quantitative?
quantitative PCR is first.
Okay, quantitative PCR, right. And if the patient has cryptic cryptic translocations, then what we do?
Translocations of what?
Sir, cryptic translocations, cryptic abnormalities.
Fish, I
Which one?
think.
Like, for example, are you talking about major root
190 to
abnormality?
30. Yes, sir. Major chromosomal proteins, major cryptic proteins.
Like trisomy 8, trisomy 19, isochromosome 17. Those one?
No, sir, I'm talking about if it is not translocation 210, if it's not BCR of size
So not
210,
not yes, not appreciated on the conventional this
if it's
diagnostic
not
test.
on the conventional probe of PCR, then what we do next?
We go for fish, I guess.
Atypical
We,
transcripts.
we haven't come across any such case where we couldn't quantitate the BCR-ABL transcripts. There are typical transcripts like
There
E13A2,
are
E13, E14A2.
there
There are some atypical as well.
fish is the answer for such cryptic lesions, cryptic mutations that are not kept by the conventional PCR. So it is written in 17 edition of 2017 edition of WHO. But these are very rare.
I think they will not be mentioned
I
in
think
2022. We haven't come across yet.
I think
Such
may I ask something? I think that cryptic translocations are not detected on the conventional karyotype or cytogenetics, but they can be detected by fish. But I had a question that you told the cytogenetics and flow cytometry. What would flow cytometry do in CML?
Sir, this question is also of mine that what is the rule of flow cytometry? What will be the result of flow cytometry in case of CML?
Yes, I
So
asked the
when you
same
do
question. Yes, yes.
so when you do a bone marrow biopsy or when you are confirming the diagnosis, whether these are only the myeloid series of the patient, then flow cytometry is a part of the bone marrow aspirate and biopsy. And we do flow cytometry for all our leukemia cases, whether they are chronic or not chronic, just to make sure there is only one disease in this patient, which is CML. Because there are cases where we have seen CLL with a small phenotype of CML as well, or CML with a small phenotype of CLL as well. The dual diagnosis patients, we have many patients who have dual diagnosis CLL, CML, CML, CLL, Waldenstrom CLL, Waldenstrom CML as well. So we do flow cytometry for all of our leukemia patients or lymphoma patients, just to make sure there is no dual diagnosis.
And I think that you told that there are 11% blasts. We can also see those blasts are really myeloid or maybe lymphoid. And if they are lymphoid, then even 11% lymphoid blast will categorize this case into blast phase.
So blast phase, when the counts are when the blasts are about 20%, you treat it as AML. The accelerated phase, where the blasts were between 10 to 20, they have been out now. Like we have only chronic phase or blast phase. Blast phase are treated as AML
But
because the blasts are usually
but
about
sir,
20%.
if there are lymphoblasts, then 22 classification says that if there are lymphoblasts, then even less than 20% blasts are blast phase.
Yes, that is correct. WHO 2022 mentioned like that. But these are not lymphoblasts. All of them are granular. They are all myeloid blasts. So we do flow cytometry in all our patients just to make sure we are not dealing with a dual diagnosis. We are dealing with a single diagnosis. And we do have multiple cases where there are dual diagnoses, and we keep an eye on them in both our clinics according to their diagnosis. Because if they are carrying CLL, they can come up at any time or they can go into rectal transformation at any time. So we cannot ignore that. All right. So we have talked about the transcripts and major root abnormalities in these patients. What prognostic score do you use for CML?
So, Carl,
What is the latest one?
Euro?
ELTS scoring system. The ELTS scoring system is the latest one that we use here in UK for the CML patients. All right. Now, this patient is a young patient, 35-year-old, who had a white cell count of 400. You have done the cytoreduction and you have got the diagnosis as well. BCR-ABL is present. What treatment would you like to offer to this patient?
Tyrosine
What is
kinase
it?
inhibitor.
Okay. So he is a high risk ELTS patient. His ELTS score is coming into high risk. What TKI you would offer him?
Sir, imatinib?
Imatinib is a standard risk drug. I mentioned that this
I
patient
think
ELTS score is high.
disentinib.
Nilotinib, sir. Nilotinib.
We usually
Or
start with the
dasatinib.
dasatinib here if there is no contraindication for starting dasatinib. What are the contraindications for dasatinib? Any pleural or pericardial disease is a contraindication for dasatinib. So any patient who has cardiac disease, cardiomyopathy, pulmonary hypertension, or lung abnormalities, you do not offer them dasatinib. So chronic myeloid leukemia came up in the Part 2 exam twice in the Viva, and they asked everything about CML, starting from um, findings on the blood film to transcripts, major root abnormalities, what drugs you would give, side effects of the drugs. If there is T315I mutation, what is the option of a drug if there is a mutation present? When would you do um TKD mutation in CML patient? And what is TFR, treatment-free remission? So be ready. These can be a question in the paper form as well, or these can be a question in the Viva. And in the Viva, the patient is usually young. They want to know fertility preservation in both male and female, and pregnancy tests in the female. Right. So the fourth case is again a 50-year-old male with progressive anemia, thrombocytopenia, and fatigue. He has abdominal discomfort as well. and the ED doctor has found a very large spleen in this patient.
Pardon me, what were the cytopenias again? Was it
So the,
pancytopenia?
the patient has progressive cytopenias, anemia and thrombocytopenia,
Okay,
and progressive fatigue as well.
right.
And on clinical examination, the patient has abdominal discomfort due to large spleen in this patient as well. So
Something is moving on the slide. Is this a cursor or?
no, sometimes when I put the oil, so the
Okay,
previous stain marks, they become plottable. So this is the power 10. And power 50.
Dr. Amir, what stage of the patient? Sorry.
Patient is 56-year-old.
Has the patient been on chemotherapy?
No, patient is not on any chemotherapy. Patient has just progressive fatigue and anemia thrombocytopenia with large spleen.
An odd looking cell there.
So are there any lymphadenopathy?
No. It's only cytopenias and splenomegaly that is the abnormal findings in this patient.
Where a teardrop cell can be appreciated in this field, along with some polychromatic and spherocytes.
Monocytosis.
So please WBC, let us see some WBC.
Yes, he looks like he has thrombocytopenia as well, and the field does not contain any white cell. This is the only white cell.
I think it's something like aplastic leukemia, sorry, aplastic anemia or something like that.
But massive splenomegaly can't be in aplastic anemia.
Plastic
Yes,
anemia
sir.
can be diagnosed on bone marrow biopsy.
They're fine.
This is true. This patient has many teardrop cells, and
It's a myeloproliferative disorder, myelofibrosis.
Any LEP picture?
Sir, what about monocyte count?
monocyte
Sir,
count
I
is 1. There are some
sir, I
whole jolly
saw
body
a
bags.
yes,
Yes.
I saw a lymphocyte having granular cytoplasm, but I can't see again.
Let me check if it something again. It's a bit reactive. The basophilic cytoplasm. Right. So up till now we have seen an astrocytosis and
What's
many.
the B12 like?
Sorry.
What's the B12 folate like? Has that been done?
B12 folate and iron studies. They are normal.
Okay. Teardrop.
So whenever there is tear
There are
dropping,
some fragmented RBCs can be seen.
yes. Whenever there is tear dropping, Howard jelly bodies, and patient has splenomegaly with progressive cytopenia, the top differential that comes in mind is myelofibrosis.
Myelofibrosis.
Although we cannot make diagnosis on on the blood film that this is myelofibrosis because the criteria of myelofibrosis diagnosis is on bone marrow biopsy, the major criteria. The minor criteria is on blood film and blood tests. So if you ask me that what is the LDH of this patient is high, 1000. So according to BSH criteria, patient should have bone marrow fibrosis grade 3 or 4 according to Barbara Day. Splenomegaly, progressive anemia, unexplained anemia, tear drop, constitutional symptom, and yes, this stuff. So because of progressive anemia, tear dropping, you would suspect that this patient has um, most likely consistent with myelofibrosis. You need to do a bone marrow biopsy for this patient to confirm your diagnosis. Because of the cytopenias, you could not see many findings on a blood film, but there is tear dropping and whole jolly bodies, uh, uh, which is likely consistent with myelofibrosis. Tear dropping is a feature of either iron deficiency anemia or myelofibrosis. This patient does not seem to have iron deficiency anemia because the red cells are normally same.
Usually, more severe teardrops at the killer sites in myelofibrosis. Occasionally blasts as well.
Yes, so because of the cytopenias, you need to see the whole blood film for the NRBC, dysplastic, neutrophil, and blast. This can be big.
Blast.
Yes.
Suspicious.
It looks like a nucleoli here,
Mm.
but looks like a
Yeah.
blast. Right. suspected case of myelofibrosis in this one. Now, again, what is the prognostic score used for myelofibrosis?
We go back.
Yeah, good. Okay.
So DIPS, so DIPS is the score that we use for myelofibrosis. Yes. So let's say this patient, before that, what are the secondary causes of bone marrow fibrosis?
Um, they are metastatic bone marrow and acute megakaryoblast leukemia and
Hairy cell
TB?
leukemia.
Sir, CMA.
hairy cell leukemia. No, sorry, not hairy.
Leishmaniasis and
Yeah.
Yes. So
inflammatory disorders, gray platelet syndrome.
the new BSH guidelines have given a table as a cause of secondary myelofibrosis, which can be asked in the viva or in the morphology question. They have categorized it as infection, like HIV, TB, leishmaniasis, autoimmune disorders like Sjogren and SLE, hematological causes like hairy cell leukemia, mastocytosis, MDS, CML, metastatic cancer, drugs like romiplostin, and gray platelet syndrome and radiation. So they all can lead to bone marrow fibrosis. So let's say this patient DIP score is intermediate 1. What are the options of therapy you have for this patient? This patient is now symptomatic because of the progressive anemia, fatigue, abdominal pain, and you want to treat him. And his DIP score came out as intermediate 1. What are the options of treatment?
The interferon or hydroxyurea, if JAK2 is positive, then JAK2 inhibitor, ruxolitinib.
Mm-hmm. Yeah. You can give anything to this patient because the guidelines have changed. Previously, we used to give ruxolitinib or fedratinib to high DIP score, but now you can give it at low DIP score as well. You can you can start with ruxolitinib. If not available, then interferon. If not available, then hydroxyurea. Or always say if there is any trial in your hospital or nearby hospital, you will enroll the patient in the trial because every tertiary hospital in UK has some trial running. So we always mention in the answer if the patient is agree, we can enroll the patient in the trial as well. All right. What is the side effect associated with ruxolitinib if you stop it suddenly?
Sir, splenomegaly and rebound of symptoms.
There is a term called SIRS, systemic inflammatory response syndrome. Usually that is associated with ruxolitinib if you stop it suddenly. And what about fedratinib? If what is the side effect with fedratinib? It's again JAK inhibitor. It causes thiamine deficiency and causes encephalopathy. So those who are going for part 1 or part 2, remember the common side effects of these drugs. They can be asked because you will be consenting the patient for these side effects as well when you are starting the medication. If you know them, it's better. They can be asked in the MCQ question in part 1 and in the uh, Viva question or as a 1 mark question in the paper form. So the last question is from parasites. This patient has just returned from Argentina or Argentine and is now complaining of difficulty swallowing. Right, so this is the power 10. For the exam purpose, if someone is coming from South America complaining of fever or difficulty swallowing, what do you think in your mind?
Trypanosomiasis.
Trypanosoma. Okay, so let's see if we have trypanosoma here or not.
Yeah, could see. Trypanosoma could see.
Yeah, so we have trypanosoma here.
See the
What did you say? Did you say cruzi?
cruzy, yeah.
Another one, but there is some artifact.
Tinoplast is quite clear, isn't it?
Yes. Let's see if we have any other one. This one maybe. These two.
Yeah.
And make it big.
That's the infection.
Wow.
Yeah.
See the tail.
Yeah. So these are Trypanosoma cruzi. So my microbiologist colleague have told me that cruzi is C-shaped. It causes Chagas disease and it has small kinetoplast, which is somewhere at the tip here. It's not visible here. This one is nuclear. While Trypanosoma brucei, which causes African sickness syndrome, sleeping sickness syndrome, is S-shaped, causes sleeping sickness, and what else? But they have the kinetoplast is small as well, I think. But they would not ask us in FRCPath exam this much detail. If you say this is trypanosoma, and according to the area from South America, most likely this is trypanosoma cruzi because it is C-shaped. C-shaped, this is enough. So trypanosoma is common in the FRCPath morphology exam. Every now and then they would give either lower or falciparum, or they would give trypanosoma cases. Right. So what is the treatment options for trypanosoma?
Albendazole.
Albendazole, mebendazole, etc., or DEC is for the worms. For the trypanosoma, I don't have any clinical experience with trypanosoma, but this is just for exam purpose. The treatment options are either pentamidine or nifurtimox or eflornithine. So if you just cramp few drug names for the worms, malaria, and trypanosoma treatment, that is enough, because you need to see them only during the exam purpose. I think rest of life you are not supposed to deal with them. So this was the last case of trypanosoma, and do you have any questions before we wind up?
Thank you very much. I enjoyed that.
Welcome. So this was the session 10. There are free sessions. If you want to donate, these are my account numbers. And if you want to give me a copy, this is the link I will share in the group. Subscribe the channel, and thank you. Have a nice rest of the weekend, and see you next week.
Thank you.
Cheerio. Thank you very much.
So what's the channel's name? Take care.
Thank you.
Thank you.
Thank you.
Thank you.